Good evening, everyone. Good morning or good afternoon from wherever you're viewing from. So it's a real pleasure today to welcome you all on behalf of the Swiss Implementation Science Network core group to the first Impact webinar for 2026. We're really delighted to have you all here and we look forward to a great engaging session. So my name is Dr. Sarah Sahal. I'm a research fellow at the University of Geneva in Switzerland, and I focus on implementation science, medication adherence, and interprofessional health services. So for those attending for the first time, I just thought I'd give a little brief introduction to Impact. So the Swiss Implementation Science Network was founded in 2019, and now we're in the 7th year, and it's grown into a strong network far beyond the Swiss borders, and that's kind of showcased by the fact that we've had over 400 registrations for this webinar, crossing 44 different countries. So Impact's mission is really to drive the advancement of implementation science in Switzerland by connecting people, strengthening capacity and championing methodological excellence, turning evidence into real world impact and supporting sustainable change in practice and policy. So this webinar is really key to that mission, and it provides us a platform to share knowledge, foster collaborations and highlight innovative work across the field. So demonstrating how research can meaningfully improve systems, practices and outcomes. So before we get started with webinar 1, I just wanted to make a little quick notice about webinar 2, which will be taking place on the 6th of May, where we'll be navigating the path to successful intervention scale up alongside 2 speakers. That's Harriet Courts from Deakin University in Melbourne, Australia, and Professor Franziska Zuniga from the University of Basel, Switzerland. So just wanted you to note that because we are hearing from an Australian speaker, the time will be shifted to 9 a.m. Central European Summer Time. So it will be at a different time to our usual 5 p.m. time slot. So we really hope to see you all back here then. And now we can kind of move along to today's webinar while we're all here, but I'll just cross a couple just housekeeping elements first. So throughout the session, everyone will be muted, but you are free to send comments and ask questions using the chat function at any time. So following the presentation, we'll have a dedicated discussion session where you can ask any questions by just raising your hand, or you can still continue to type your questions into the chat function. Before I kind of ask the questions from the chat, I will ask if the author would prefer to personally ask the questions. But if you do feel more comfortable with just me asking the questions, if you can just indicate that in your comment, and I'll ask the questions on your behalf. So it's now with really great pleasure to introduce Professor Cecilia Vindrola. So Professor Cecilia Vindrola is the Director of the Rapid Research Evaluation and Appraisal Lab and the Deputy Director of the Central London Patient Safety Research Collaboration. She is a medical anthropologist with expertise in applied health research and rapid qualitative research evaluation. She is a professorial research fellow in the Department of Targeted Interventions at the University College of London. And we are really lucky to have her here to discuss how to make implementation science accessible to busy clinicians using rapid evaluation methods. So Professor Vindrola, thank you again for coming, and the floor is yours, and you're welcome to share your slides now. Thank you so much.
Thank you. Thank you so much, everyone, for joining today, and thank you for the invitation. Really happy to be here. Just going to share. Let's hope this works. Fingers crossed. I love the music as well at the beginning. It made me feel like I was on an adventure. All right. Yes. Yes. Good. Everyone can see. Excellent. Well, thank you so much. Yes, perfect. Thanks so much for joining today. I'm hoping to make it entertaining. We've got quite a few minutes to cover this really big field of rapid evaluation. And the way in which I thought about the presentation was, to some extent, to give you a flavor of the field of rapid evaluation, to give you a sense that it's not necessarily a recent field. It's a field that has a really rich history, and I hope to touch on some of that today. There is a limit to what we can do in 30 to 40 minutes, but give you a sense of where it's coming from, what its main principles are, but also a sense of where it's going, some new methodologies, some new approaches, and make it as accessible as possible. So an interesting thing about rapid evaluation is that actually it's becoming quite a common tool, not necessarily only used by those who have traditionally trained in evaluation or in health services research, but actually it's being picked up by people who might have come from different backgrounds. And we train clinicians in particular very frequently so that different bits of rapid evaluations can actually be incorporated into routine practice. And looking at rapid evaluation approaches as a way of doing more regular monitoring of current service delivery, attaching evaluation methodologies to the implementation of new interventions and programs. So hopefully after today, you'll get a sense of the different ways in which evaluations can be used in a more rapid and responsive way within quite stressed and under pressure healthcare systems. We'll touch on different ways in which you might maybe take little tools and techniques, perhaps not an entire rapid evaluation design, but picking out aspects of the work that you might find suitable to your kind of daily needs. But also I want to come back to the idea of looking at different ways in which we might go for a design that is particularly rapid, but without sacrificing the rigor, without sacrificing the quality. And I'll spend some time going through STREAM, which is the first kind of standards or set of standards for rapid evaluation and appraisal methods, to bring us back to this idea that yes, we could do rapid research, we could generate findings so they can be used to inform changes in policy and practice, but what are some of the key things that we might still keep in our design to ensure that those findings are robust? So without further ado, I will take you through some of these slides. I might move quickly just because of time pressures, but we should have some time towards the end for questions. The first thing I like to do is to introduce you to our team. And the reason for that is a lot of the work that you'll see here today is actually produced by a quite large team of qualitative researchers interested in implementation science, interested in rapid approaches. And so I like to introduce them with this little animation.
The Rapid Research Evaluation and Appraisal Lab uses research to improve healthcare systems, programs, and interventions delivered in time-sensitive contexts. REAL is a multidisciplinary team with expertise in qualitative and quantitative research. REAL delivers face-to-face and online training, carries out rapid literature reviews, quick appraisals, rapid ethnographies, and evaluations, and advises other teams or organizations on the use of rapid research approaches. Current areas of research include the organization and management of healthcare delivery, the use of rapid qualitative research in clinical trials, global health and complex health emergencies. For more information, please visit our website.
Now you kind of know the who there, right? You know the team, but what is the why? Why do we do the work that we do, and why is that important to you? So a lot of the methodological, I suppose, innovation and some of the work that we have been developing over the past 10 years really stems from an interest to make research and evaluation useful. So we have been doing work trying to set up our team as a rapid response team for quite a few years, trying to generate an approach to research and evaluation where we can quite rapidly adapt to the needs of the system. That becomes really relevant in the case of complex health emergencies, global pandemics. We tend to think of rapid response teams in those ways, and definitely an interest in the team during early stages was around, how can we generate findings, either look at existing evidence or generate new evidence so that those findings could be rapidly translated into action, forming public health authorities, forming policy, etc. But over the years, we started to really map this field and trying to understand, well, what has been done before? What are some of the rapid tools that we can learn from that history, and we can start to develop some of these new approaches? And we were finding that there were quite a few different approaches, from rapid appraisals, rapid assessment procedures, different types of rapid ethnographies, also rapid evaluations and rapid evaluation methods that we could draw from, and then look at different ways in which we might apply them in our healthcare system. And this, yes, of course, covered complex health emergencies, but also started to make us think about ways in which we can develop a more agile way of doing research and evaluation within our current healthcare system structures as well. And in this process of digging around and looking for the literature, we came across quite a few quite interesting questions, like the one posed by Scrimshire Hurtado right here. Researchers already asking themselves, do we need to spend a year in the field? Do we need to spend a year collecting data in order to make useful recommendations for a health program? And what this really allows us to think about is this concept of timeliness that McNally and colleagues have highlighted as essential in the ways in which we do research and the ways in which we carry out our evaluations, where timeliness is one more variable that we're considering. And we're really interested in this idea of, because of the time in which we might share findings, that impacts directly on the use of research, right? So only findings shared at particular time points can inform changes, can inform decision-making processes. And some topics, some of the research that we will look at will be time sensitive, right? So only if we're capturing those processes, practices, or perceptions are we in real time, are we able to get, that level of detail, the richness. So we always say some research might need to be rapid, or some evaluations might need to be rapid, because not all contexts or topics might be appropriate. And that is something that we'll come back to today, situations where you might not go for rapid design. And there's been lots of debate in the field in terms of how we define these approaches. And I think one of the early attempts is this review by McNally and Foster-Fishman, where they're trying to create what they call more of an umbrella definition. And the way in which they design these approaches is by highlighting the 4 key elements that I've circled for you here in this slide. So these approaches, and they kind of group everything together, right? Research, evaluation, appraisal, it's all under one. They tend to be rapid in the sense that you can carry out the study anywhere from a few weeks to a few months, tend to be participatory in the sense that you might involve community members or other stakeholders in stages of design and implementation, tend to be team-based, so you could recruit a team and cover more ground. You could have more people carrying out data collection in parallel, bring in more people during a stage of analysis to speed up the process. And they tend to be iterative, so this idea that they're made up of multiple repetitive cycles informing each other, or even carrying out different stages in parallel, which is something that we'll come back to today. No real consensus in terms of what we mean by rapid. So you can see here different timelines proposed, anywhere from a few weeks to a few months. If you start to look at some of the published systematic reviews, again, lots of variation in terms of timescales. Here as well, really tight timelines, a few days, and this is of course in the context of complex health emergencies. In the case of rapid ethnographies, again, a bigger range here in terms of study duration. Lots of variation in terms of how you might carry out rapid research in conjunction with longer term research as a standalone piece, informing a longer design in parallel, or actually as a preliminary study to then inform a longer piece of work. Variation in terms of terminology and the different slight, I think, differences between all these different approaches. Quite an arbitrary distinction here between research and evaluation, but just to give you a flavor of some of the terms that you might see in the literature. And today we'll focus more on rapid evaluations because that's the area of interest. But I think it's important to consider that rapid evaluations are also, to some extent, influenced by some of the other approaches that come more from a more traditional research field. And one of the things that we'll focus on today are all the different strategies, the tools or techniques that have been developed to be able to facilitate some of these features that you see here. This idea of carrying out data collection and analysis in parallel. And our team traditionally does a lot of more qualitative research, so we tend to focus on things like process evaluations that look at implementation processes that match an implementation timeline. So we might talk about different types of rapid formative evaluations. So we'll look at how we might do that with qualitative data, which tends to be normally thought of as quite a complex approach, normally having to, requires a long time to be able to collect data through tools like interviews, focus groups, and observations. But actually, some of the things that we'll look at today are different ways in which we might simplify some of these approaches and still be able to carry out analysis in real time. So I'll come back to some of these as we go through one of the case studies today. But important, I think, to start the conversation with rapid research and evaluation is the challenges that we know that we will always have. So I've mentioned before that, not all topics, contexts, etc. are suitable for a rapid design. We're always under this tension between the breadth and the depth of data. So the moment that we want to cover more ground, because of time pressures, we might be losing some of the richness. And that's something that needs to be factored into the design of our rapid evaluation. So making sure that it doesn't prevent us from answering our key evaluation questions if we decide to build a larger sample size, for instance. Many times we think that potentially rapid evaluations might be limited in terms of who they're able to reach. So we talk about time pressures and having to rely potentially on people or populations who are easier to access. What does this mean for harder to reach groups or underserved populations and vulnerable populations? Are these being excluded from more rapid approaches? We also talk about the importance of team-based research, but we don't necessarily always reflect on the issues in terms of managing a team, right? So more people, many times more problems. So how do you manage a team where you might have different levels of experience? How do you manage a team so that data can be collected and analyzed consistently, especially if you're having members of the team doing this in parallel across different sites? So we'll look at some tools and techniques today that can facilitate that process. Now, within this field of rapid evaluations, which is very intimately connected to rapid research, we start to see some terms appear in the literature that look like these. Now, this was an early attempt from the team to try to map what rapid evaluations look like in healthcare. I have another review that I'll talk about a bit later on, which is slightly more recent and covers rapid evaluations beyond the healthcare sector. But these are the terms that we see frequently mentioned in the literature. So rapid evaluation methods, rapid feedback evaluations, and rapid cycle evaluations. Now, in the case of rapid feedback evaluations, these resemble more of a process evaluation, formative evaluation type of design. They normally run in parallel to an implementation kind of timeline. And what they entail rapid kind of stages of data collection analysis, sharing of findings with the implementation team so changes can be made in the rollout potentially of an intervention or a program, and then the scheduling of another kind of cycle or loop of rapid data collection, analysis, and sharing of findings. So we see these kind of multiple loops designed across potentially a slightly longer timescale that we would normally be accustomed to in the field of rapid research. But again, having these intensive periods so the findings can be shared. Now, in order to do that and to still maintain the quality of the findings, rapid feedback evaluations, as you see here in this slide, tend to be quite focused, tend to be very, very discrete questions to answer. They tend to be directed at particular audiences. And of course, they tend to be quite rapid in terms of study duration. Key examples, and I have thrown some of these along the way in case you want to do some further reading. So one of the most kind of famous published examples is this study here. And you can see already the kind of definition of these different cycles, and they might rely on looking at existing data or collecting additional data, but still embedding these processes of analysis and the sharing of those findings. Rapid cycle evaluations tend to have a similar design. Again, this idea of embedding these cycles on the sharing of findings along the way. Sometimes the terminology of rapid cycle versus rapid feedback loop, rapid cycle tends to be associated more with the quality improvement literature, this idea of PDSA cycles. So I think that's mainly the reason why there's a change in terminology. But rapid evaluation methods are slightly different in the sense that they tend to be a little bit more summative, many times carried out after implementation has happened, shorter in duration, perhaps a few weeks to a few months, and they might involve a series of recommendations for changes that need to be carried after implementation has finished. So less formative, I suppose, in their design. I'd like to include normally 2 examples of rapid evaluations when I carry out presentations like this one, just to give people a flavor of what they look like in practice, but also to question some of the dominant assumptions. And one of the dominant assumptions that I've seen is lots of people feel that rapid evaluations will always tend to be quite small in terms of sample size, and also will tend to be very site-specific or single-centered. And I like to point them in the direction of evaluations like this one, for instance, that actually you can see they've taken over multiple global contexts, quite a large sample size, particularly for some of the qualitative methods that are being used. And examples of evaluations like this one, again, 21 primary care practices, which is quite large, I suppose, for rapid evaluation, but still quite an important piece of work, and integrating into an evaluation like this one, a very commonly used conceptual framework, which is the CFIR, to look at the different domains of implementation. So embedding, again, a conceptual framework, making it quite robust in terms of its design, and still allowing the research team, even though study duration, as you can see here, is 5 months, still allowing the evaluation team to cover quite a broad area. So just some examples. And overall, what we're finding in terms of some of the strategies that the rapid evaluation teams are using to deliver these evaluations in a short amount of time and still produce some robust findings, they center on this idea of, okay, well, let's use teams of researchers. Let's make our research participatory in different ways to facilitate, of course, running the studies in a short amount of time, but also to make sure that different points of view and experiences are represented from the very beginning. Let's establish these feedback loops so we can disseminate findings as the evaluation is ongoing. And then this idea of building in different kind of structured manuals, guides for data collection, and we'll come back to the use of kind of tables to maintain that consistency across members of the team, but also to facilitate analysis so that we can do this in a more rapid way. So I just want to give you a little bit more flavor of how we might do this in practice. And I'm just going to go through all the different stages and, throw some ideas around in terms of techniques. And then I want to come back to this concept of quality and maintaining the standards in the work that we're doing, so that even if we are doing rapid research, or rapid evaluations, we don't want to, for rapid evaluations to be associated with this idea of, oh, it's a quick and dirty exercise, or you're cutting corners. So we'll come back to this concept of standards in a little bit. But how do we do this in practice? So one of the things that we always say with rapid evaluations is that many times the preparatory and design work that we do, especially because we're integrating a stage called a scoping study, many times it takes longer than actual data collection. And the reason for that is that if you are going to do a rapid evaluation, you want your questions to be focused enough, targeted enough, so that you can answer them within a short amount of time. And a lot of this preparatory or scoping work, I'm sure will not surprise you, requires, of course, identifying the published literature, what's already been done, what are the gaps, looking at different approaches, of course, to reviewing the existing evidence. But you might also want to integrate a very discrete piece that we call the scoping study. So scoping studies tend to happen a little bit before, there we go. A little bit before you actually roll out your rapid evaluation. And here I've given you a timeline of 6 weeks, but we've done scoping studies in about a week or 2 weeks. It really depends on the overall time frame of your rapid evaluation. And the idea is to carry out some quite rapid and like snapshots of what's happening in terms of what's happening with the intervention that you're evaluating, what's happening with the general context, what has been done before, is this evaluation replicating perhaps existing evaluations. So the idea overall is to get a snapshot of that situation and help use this information to define the areas that need to be covered. So that's the idea of scoping. So it helps you to identify the scope of the rapid evaluation, agree the research questions, agree the methodology. So what are the methods that are going to be used to collect and analyze data? Agree a timeline and develop a process for the sharing of outputs. And to some extent, scoping studies also function as an availability assessment in the sense that they might highlight some red flags and some reasons why we might actually want to avoid or abandon our plans to carry out a rapid evaluation. So scoping studies could have their own questions, and I've outlined a few for you here. So many times we're asked to come in and to do a rapid evaluation of, let's say, an intervention or a program that doesn't necessarily have a program theory or a logic model that's guiding it. I know, shocking, but it is more common than you would think. And so many times we're using that scoping study to really try to tease out that program theory or that logic model, right? The aims of that intervention or that program, the outcomes it's trying to achieve, the mechanisms through which it hopes to achieve those outcomes. We do a scoping study to identify who are the main stakeholders, what are the main components of that intervention. Has anything already been done? Has anything already been studied? Is there an existing approach for the collection of data? Is there a baseline? Is there any routine data collection? What are the aspects of that implementation process that we still need to document, and what are the best methods that we should be using to document them as well. And a key thing in any type of rapid evaluation, especially those where you're building in these rapid feedback loops or cycles, is when are findings needed? So what are all the different time points when the evaluation team has to be prepared to share findings? And that is incredibly important. It's discussed from the very beginning, even though I'm going to talk about dissemination towards the end of today, but discuss at the very beginning, and it frames everything that we do from then on. So we'll involve different people, of course, during some of these conversations, some of the meetings, the observations, some informal interviews potentially at this stage, trying to really look at people who might be taking on different roles, from people taking part in the implementation teams to those who will ultimately be the users of the services in that new intervention or program, people operating perhaps at a senior level, those delivering some of the services on the ground, people who might be in favor of the intervention, those who might be against. So this idea of documenting and bringing together people who have different points of view. And overall, what we want to leave, the outcome, I suppose, of that scoping study is, first of all, an agreement regarding whether we should proceed with a rapid evaluation. So again, coming back to this concept of scoping as an availability assessment, the idea that you might be making a decision at this stage to abandon the plans to carry out an evaluation altogether, or you might have decided that a rapid design is not appropriate. And various reasons, I've outlined them here in the slide for you. These are all reasons why we've abandoned plans at some point, whether implementation was not going to occur at the original time that was proposed, and so there's no way that you can do a rapid evaluation if implementation hasn't happened. Data that we were potentially promised will ultimately not be available. The team cannot access the space. The people cannot observe where they're meant to be carrying out observations. There might be a negative impact of evaluation findings, so producing unintended consequences. Lots of reasons why we might decide that rapid evaluation design is not appropriate. Now, if we do decide to move forward with the rapid evaluation design, because we've done that scoping study, we tend to have then enough information at this stage to either test an existing program theory or logic model, or to develop one from scratch that will then guide that rapid evaluation. So outlining potentially the rationale for the development of that program, the different activities or main components, what is expected in terms of those outcomes. And the key thing for us is always that middle column right here. What are the perceived mechanisms for change? What are the mechanisms that will tie then those activities to those expected outcomes? So then we're starting our evaluation with a little bit more knowledge of what's happening. We've made a decision that it's all right to proceed. We have that starting kind of logic model, program theory to guide some of our thinking. We then go into our design and we look at all the different, I suppose, variables or the different factors that might shape the type of design that we want to go for. And this is all, of course, dependent on our research questions, whether we want the evaluation to be participatory in any way, how structured we want our data collection and analysis to be, the size of the team, whether it's operating across multiple sites or whether it's a single-sited evaluation. And again, this idea of when are these feedback loops embedded, when are findings needed to inform any decision-making processes. And what really makes, from a methodological point of view, you will see the description of rapid evaluation methods, particularly those that have more of a process evaluation design or are really interested in capturing factors that might be acting, for instance, as barriers and enablers in implementation. They tend to draw from qualitative research methods that everyone is used to. So what I think really allows us to think of rapid evaluations in a slightly different way is this approach to do all of these different things in parallel. And one of the tools that we've developed to be able to facilitate that real-time analysis of, particularly of qualitative data, is the real rap sheet. Now, the real rap sheet really emerged out of a need to maintain consistency across members of a really large evaluation team. So we had requests to carry out national level rapid evaluations. We had a team of sometimes 6, 7 researchers who would be operating all in parallel, all scattered across the country, across different hospital settings. And a question we had is, how are we going to ensure that the team as a whole is really approaching data collection and analysis in a consistent way? And so we started to look through the literature, trying to see what other people had done. We came across, in the field of rapid assessment procedures, that's why you see the acronym RAP, we came across a tool that was being used around the 1980s in RAPs that was called the RAP sheet. And the RAP sheet was normally a tool not necessarily used to facilitate data collection and analysis, but it was actually a tool that was used to share findings after a RAP had ended, and they wanted to share findings across different communities in a kind of consistent way. So they developed this. It was a one-pager. It was incredibly nice to see. It had the aims of the study, the methods, and the key findings, and it was shared across multiple communities, many times even translated into different languages. And it just became a really good way to disseminate that information in an accessible way. And some of the questions that we started to ask ourselves was, what if we created something that actually functions as a working document, something that we can alter as data collection is ongoing? It gives us a snapshot into the data set, but we're all using the same tool, so it's maintaining that consistency. It grows as the study starts to get more insight into what's happening locally. As it's growing, it allows us to get a sense of, well, what are some of the areas where we've reached saturation, right? This is just repetitive. We kind of know everything we need to know, but also it allows us to identify gaps. And when you are pressed for time, identifying gaps early on becomes something incredibly useful. You don't have the luxury to return to a particular site. You don't have the luxury to extend your study. And so addressing gaps early on becomes something quite useful. And as well, because we are working in a more formative way, if we have an implementation team that is asking for findings at different time points, because we have this real life repository of our data, we can share findings at any point. So I have a short animation just to walk you through the real rap sheets, and then I've got a few things where I can show you some examples from some studies.
REAL has adapted a tool originally used in Rapid Assessment Procedures, or RAP, to facilitate the collection and analysis of data in rapid qualitative research. RAP sheets are a table including the main categories of information collected in the study. These categories are based on the research questions, theoretical framework, or data collection instruments. As an interview is carried out, the researcher takes notes, even if they audio record the interview. The researcher then summarizes the key findings from the notes and adds them to the rap sheet. When she carries out an observation or another interview, she adds the key findings to the same rap sheet. The researcher will do this for each data source using the rap sheet as a triangulation tool. The rap sheet will start to grow in length. Some topics will repeat themselves, but gaps will also appear. These gaps can be addressed as data collection is ongoing. Different types of rap sheets can be created, one for each researcher, each study site, population, or to capture changes over time. The rap sheet can be used to discuss emerging findings and obtain feedback from members of the team or stakeholders, prompting changes in the study design. If changes are made in the rap sheet, all researchers should make the same changes to maintain consistency. Rap sheets help create a quick summary of findings, but they also guide researchers as they set out to conduct more in-depth analysis. There are many creative ways to use rap sheets. Visit our website for more information.
So nothing fancy, right? This real sheet is basically a table like the one that you see here with an initial column that summarizes the key categories of information that we're interested in our evaluation. These can be framed, of course, by the questions guiding the evaluation, any type of data collection instrument that might be used, such as an interview topic guide, discussion questions and observation guide. And as the study starts to progress, the researchers will create summaries of interviews, observations, focus group discussions, and will add them to this sheet. So it will start to grow in length, as the animation said, but it will give us a constant kind of reflection of what's coming out in our data. The team will then meet frequently. I always say it's not so much about the tool, it's about the process that the tool will facilitate. So the idea is the team will meet frequently to discuss what's coming out across the different sites where they might be working, discuss any changes that might need to be made to the tool, and if changes are made, then everyone makes the same changes. Again, this idea of consistency. Team will discuss what are some of the findings where we might need to dig a little deeper to get more information, where are some of the gaps in the evaluation so far, and how can we address them. At any point in time, summaries of the across rail sheets can be made to share findings, emerging findings or preliminary findings with anyone who might need them. But then we can also use that rail sheet as a way of creating different kind of packages of our data. You might have one per researcher, as we discussed before, but we might also be packaging our data so that we are creating case studies across the different sites. And we do this a lot when we do rapid evaluations across multiple hospitals in different regions of the country, where we create a real sheet per hospital site. And then we're able to do some quite easy cross-case comparisons across the different tables. We might be working with different populations, perhaps doing a real sheet of all the data obtained from a patient population versus the experiences or the perceptions of members of staff, and we might be comparing in that way. We might be creating different real sheets across different time points, so this becomes really important. You might remember when we talked about these different loops or cycles, we might have a real sheet at a pre-implementation stage, during implementation, and perhaps at a post-implementation stage, and look at changes over time. And because the real sheets bring together data from all of our different data sources, they start to function as a triangulation tool quite early on. So not as an after the fact, I've got data from an interview, observation, documentary analysis, but from the very beginning. So we're able to start to really look for trends that might be coming across our entire data set, where data sources might confirm each other and where we might have some discrepancies as well. Of course, it doesn't have to stop here. In very, very rapid studies, we sometimes stop our analysis at the stage of categorizing in a real sheet. It might create some higher level summary so that this can be shared. But most of our studies do allow us to do a little bit more in-depth analysis. And what we have done, but as well as other teams who have used the tool, is to use the real sheet as a way of guiding that in-depth analysis, and perhaps then relying more on what are called table-based methods, which still allow us to get a glimpse into our raw data. So framework analysis is quite popular one. Still going back to our data set and trying to map, using perhaps the real sheet to guide that topic selection at the top, but again, going back to our individual cases and being able to create that connection with the raw data so we don't miss that level of detail. A lot of it does depend on time pressures and, of course, the level of detail that's needed to answer the questions guiding the evaluation. I said I would talk about dissemination at the end, even though dissemination is one of the key things that we look at the very beginning of a rapid evaluation. Here are some of the questions that we ask ourselves at that scoping stage that you might now remember. What are we trying to do with dissemination? What is the type of dissemination that we're trying to do? Is it just sharing of findings? Is it actually about getting feedback on those findings and then making changes in the evaluation design? Who needs to be involved? Who are the stakeholders in this particular evaluation? What are the preferences in terms of formats? How are the findings going to be used? And this allows us to create a dissemination plan from the very beginning. You can see here a timeline of about 6 months of work, incorporating that scoping familiarization stage during early stages around kind of weeks 1 to week 3. And the key thing for us is always this column in the middle, which is all about the purpose of dissemination. And then everything else is designed in relation to that, right? Depending on what we want to do with dissemination, we will look at aspects of the timeline, the type, the format, and who needs to be involved. Now, I said before, a key thing I wanted to cover today had to do with quality, and the reason for that is, if you work in this field of rapid research and evaluation for over 10 years, you get a little sick of hearing, well, if you're doing something rapid, it will never have the same quality as a longer term study. It's you need to cut corners in order to deal with time pressures. And some of the work that the team has been doing over the past few years has actually been to question that in different ways. And a lot of, the things that we have done has centered on, well, how can we do this in a more rapid way? And the reason why we think about rapid research is going back to that initial, I suppose, question of why do we do this? And the idea of doing rapid research and evaluation is all about being able to generate findings so that they can actually be used to inform decision-making processes, so they can be used to inform changes in practice and policy. And we live in a world that is rapidly changing, and we work in healthcare systems that constantly demand new evidence to inform those decision-making processes. So the key question driving the work of the team has been, well, how can we do that? How can we do it so it's still trustworthy and so we still maintain the rigor and the quality of our work? And that's where the idea of creating Stream first emerged. We knew there were no standards out there for rapid evaluation and appraisal methods, and we wanted to develop something that could act, first of all, as a guideline, especially for those embarking on rapid evaluations for the first time. So guidelines to help you design and implement your rapid evaluations. Reporting templates, because we were finding in all the different systematic reviews that I've shown you so far, a key conclusion from those was lack of transparency in reporting. We don't know the methodology. We don't know the sample size. We don't know the recruitment approach. We don't know if changes have been made along the way. So coming back to this idea of, if we are transparent in how we report our evaluations, then as a community, we can learn from each other and we can further develop this field. And again, this idea of using Stream as a quality assessment tool, in a way, looking at it as a potential checklist, has the evaluation team thought about all these things? Have they reported all of these different things? And it starts using a systematic review methodology, as is very common in the development of any type of standard or guidelines. Just wanted to flag that this is a more recent review looking at rapid approaches to research and evaluation beyond healthcare, so including healthcare, but looking at other sectors as well. So hopefully this is helpful for you if you're just starting out in this field. Then we use those systematic review findings to shape quite a few other stages of development, looking at an eDelphi process to reach consensus, and then actually running some collaborative workshops to test Stream, to pilot Stream. And now Stream has been used in quite a few different published studies, and we're in the process of developing a timeline to continuously review and update them as well. So I won't go through this process, but I did want to introduce you to some of the different components of Stream in case they're useful in your own work. You can find them here. But as you'll see, they're basically covering all the different stages in study design, encouraging researchers to provide kind of clear descriptions and definitions of the different stages, from rationale around, why have you selected a particular type of rapid design, any type of theoretical frameworks or conceptual frameworks that might have shaped the ways in which the questions are asked, any changes made along the way as well. So you've proposed a particular study duration, but your study ended up taking longer. What are some of the reasons why those changes were made? And as I said before, a lot of this is just to help us as a community understand, well, what are some of the key factors acting as barriers when we try to implement some of these rapid evaluations? So looking at different ways in which we might be transparent about the evaluation of the research team guiding that rapid study, different ways in which we might think about the training, the expertise, the skill set required in some of these teams, looking at different methods for data collection and analysis, and particularly if any of these stages run in parallel, how do these evaluation teams facilitate that real-time analysis of findings as well? Looking at how results are interpreted, if different findings are shared in particular time points. So this idea of is there ongoing dissemination, and how is this facilitated in practice? Then transparency around impact, and sometimes it's difficult because impact potentially doesn't happen until after you've published your own article, but are there thoughts about how these findings might actually be translated into those changes in practice? Are there mechanisms put in place to really inform these decision-making processes? And then, of course, clarity around governance and accountability. And governance is a very, very important aspect, because a lot of the ethical review processes tend to actually function as some of the factors that create considerable delays for research teams and evaluation teams trying to set up and carry out their studies quite rapidly. And we can come back and I can tell you some horror stories about delays with ethical review committees, as well as with publication timelines. And just to wrap up, because I also can see I'm almost out of time, a few things to think about, I guess, moving forward. And there's still a lot of uncertainty that in terms of how we might use these rapid approaches in research and evaluation in a better way, I suppose. I think the field has grown considerably, but there's still a lot of debate around how we might define rapid, how we might define some of these approaches when we use them in practice. Stream is out there. It's been developed as a tool particularly for teams that might not run rapid evaluations in a more frequent way. Still relatively unknown, so a lot of the work that we're doing at the moment centers on dissemination of Stream as a tool accessible to everyone. We feel that additional testing needs to happen in terms of rapid evaluation designs. From the very beginning, the caveat in the presentation today was, these are approaches that can be used in some contexts. We don't want, wouldn't want you to leave today thinking, oh yeah, I could run a rapid evaluation on absolutely everything. So looking at suitability and when is it appropriate to run a study using a more rapid design. When you work as a rapid evaluation team, many times these teams are considered high risk. The idea behind this is that many times rapid evaluation funding comes in little pots because you're doing a study that's maybe a couple months long. And so as a team, it requires a certain infrastructure, certain flexibility, adaptability, for instance, of a team that can survive on multiple, I suppose, rapid and more short-term studies. It also requires a team that can incorporate new members within short amounts of time, potentially to assist with specific stages, like massive team to be able to collect data in a short amount of time, which then becomes a smaller team during stages of potentially write-up or dissemination. So it requires that level of expansion, which is not always, it's not always possible, I suppose, in more rigid and traditional academic systems where many of us work. And that comes to my last point. A lot of the work that we're doing at the moment is focusing on creating resilient systems. In our case, in healthcare, right? Trying to look for different ways in which healthcare systems might adapt to a wide range of both internal and external pressures. And the argument that we would make is that research needs to mirror that. So the creation of resistance systems in healthcare also needs to be accompanied by dynamic and adaptable, flexible methods for research and evaluation that can accompany the implementation of new programs and interventions, but where findings are not shared 3-4 years after implementation has happened, but where findings are shared in real time so that they can actually be used in practice. And that's all from me. You're probably happy that I am finished. You don't have to hear my voice. There you go.
Thank you so much, Cecilia. That was a really great presentation. It's wonderful to hear about give an intro to the methodology and understand how we can actually integrate that into practice or some of our implementation methodologies. So there has been already a few questions already in the chat. So for everyone that's watching at the moment, we have the next 30 to 35 minutes where we can discuss and ask Cecilia some questions. So please write them in the chat or just raise your hand and I can give you the floor. Perhaps to get us started, we have a question from Mary Paul. Would you like to ask the question yourself or just give them a chance to...
Yes.
There we go. Thanks, Marie.
Thank you very much for your presentation. I have a question. I think you give part of the answer at the end of your presentation, but it's about the size of the team. When you do rapid evaluation, you need a big team. But how do you put together this big team? And do you share researchers between different teams, or how do you do it? And how do you fund it? Thank you.
I think you've touched on a really important point, and especially a point that's that kind of behind the scenes that we normally don't talk about because we don't put that in a paper, right? You never know how this is done. So it's been a process. So when we first started the team, it was only 2 of us and we were working with really, really small pots of money because that's the only thing that we could do. And we had to develop that track record over time so that then when we bid for bigger things, we could say, oh, and we've done, all this work. So we started slow. But one of the key things that I think has worked really well is when we created the team, we created it using a hybrid model. So we are a team that's based at UCL, so based at a university, an academic institution. As a result of that, we need to, in a way, bid for academic funding, your traditional academic funders. And the UK has a key one, which is called NIHR, which is the equivalent, I suppose, to NIH in the US, right? It's all about funding health research. And there's a few other different councils that we might go for. So there is, in a way, a requirement for the team to submit bids to that. But from the very beginning, we knew we wanted to, because a rapid response team could actually generate research and evaluation for a wide range of organizations, we wanted to be able to bid for projects from non-academic organizations. And in order to do that, so UCL has, it's called a subsidiary. So there is a track that's called UCLC, UCL Consultants, and the work that they do is all about connecting academics to industry, to public organizations, so that they can act as advisors. And what we did with the team is we really formalized that channel. So for instance, we have a person from UCLC who's appointed directly to our team, who will constantly scan for bids, calls for tenders, etc., knowing the expertise of the team. And to be honest, over the past few years, I would say most of the volume, perhaps not necessarily the amount of funding, because the academic grants might be, a few £1 million, but these projects are smaller and more discrete budgets. But in terms of volume of projects, most of them have come from that stream. And what that allows the team to do is to have a constant flow of consultancy work. Some of them are rapid reviews of the evidence. Some of them are rapid appraisals. Some are rapid evaluations. Some might also take over a longer period of time, like perhaps 2 years, and we can fund researchers for a longer period of time. But it allows the team to have that kind of crossover between two different funding bodies. Now, the landscape in academic funding, I don't know what it's like in continental Europe, but at least in the UK, is changing, and it's reducing, and it's becoming harder and harder to get projects funded. It's becoming very project specific, less kind of infrastructure grants. So for us, that stream that we've already been able to create and where we have that track record, I think is going to become more and more important in the future. So diversification, I suppose, would be an advice in terms of creating these types of teams. We also generated another pot for the team through training. So developing training, the CPD kind of model, this idea that short courses online, and using that as a source of creating income, which is then fed back to the team and can be used to fund projects where we might not be successful if we bid externally. So there's quite a bit of, especially the methodological innovation work, which is sometimes harder for an external funder to. Definitely not funded through consultancy, because if you're commissioned to run a consultancy project, it's for a specific, project where you need to deliver. Some academic funders, for instance, Stream was funded by UKRI, which is a research council funding. So yes, but a lot of the methodological work then we fund internally through income generated through training. Mm-hmm. The size of the team varies. So at the moment, we've got 12 qualitative researchers who work mainly full-time and across 25 projects that run in parallel. So relatively big, especially for a rapid response team. Now, what we have is we have a model, because we have the kind of different funding pots. They work and they have a contract through the university, so it's a more traditional model of hiring them. But then what we have in parallel is a pool of researchers who work as freelance. And our university allows us to hire temporary workers and to do it quickly. My main issue with expanding a team is that in a university human resources process, if I have to advertise for a new role, interview a new it could take months. And by the time that's done, the project is finished, basically, or the findings were needed yesterday. So this allows us, by having a pool of freelance researchers that we can hire from one day to the next, and they could still be paid through kind of a university channel. At any point in time, we can rapidly expand the team. So we're just finishing, for instance, a rapid review that had to be done in 3 months. It was led by one of the key researchers from the team, the one who we have a sub kind of group that does all of our systematic reviews. So she's a systematic review expert, but she needed at least 8 people reviewing screening in parallel. So we just expanded quite rapidly with our freelance researchers, and then they know that the project ends on X date, and then we revert back to a smaller model.
Thank you very much.
Sure.
Wonderful. Lisa, there's a question from Lisa Lederer. If you'd like to ask your question.
Sure. I guess my question is related. So you've talked a lot about the implementation team and the evaluation team operating in parallel. How do you feel about whether they have to be completely separate? Because in the health services world, there's often a randomized control trial alongside a process evaluation. There's obviously risk of bias, but it's a lot easier. So what are your thoughts?
Yeah, I think you're describing, common debates in the evaluation field, right? Do you have that evaluation team as a completely separate objective team that doesn't interact with an implementation team or a clinical trial team? Or do you have more of a collaborative model? In our experience, and we're based in a very clinical division. So our team is based in the division of surgery and interventional science, and a lot of clinical trials run out of that division. And part of the expertise of the team is to develop the kind of qual SWOT, so SWOTs within trials, or that process evaluation that runs alongside an RCT, for instance, that will capture aspects of trial implementation, but will also capture aspects of staff experience of implementing, patient experience of taking part in a trial, withdrawing, declining, a more traditional kind of model of a qual SWOT. Our experience of working alongside implementation teams is that, in general, I would say that the quality of the work is better if there is some sort of collaboration. So I think that collaboration with either an implementation team, if it's, an intervention or a program, or collaboration with a clinical trial team, gives us insight into implementation that if we try to maintain that distance, we wouldn't have. It gives us access to participants, access to sites that in other experiences where we've tried to be quite separate, that's always been an issue. It allows qual findings, I think, to be taken seriously. The idea that, we're in this together and we're generating qual findings that ultimately you need to make sure that there are no barriers in your, recruitment targets, that you don't have delays there, or that, you're facilitating implementation across sites in a consistent way. You don't have that variation. So then when you're looking at outcomes, you don't understand why you've got some results like this here or there. So I think it really allows, if you're able to communicate that message to the trial and the implementation team, that the work that we're doing from a process evaluation point of view is also of use to them along the way, as well as in that final stage of analysis where they'll look at outcome measures and might not be able to explain it without your findings. I think that becomes a better experience for the evaluation team and ultimately produces better findings. So I'm more of the camp of collaboration and partnership is key. We always talk about maintaining critical distance. So the difficult here is if we're all friends and you're working with an implementation team who really wants a particular outcome out of it, it's important to be able to manage those conversations. So we talk about being critical friends and saying, look, you brought us in to do an independent evaluation of this intervention, this program, the trial. If things are not going well, we will be responsible to tell you. Now, we won't just tell you it's not going well. We'll tell you it's not going well because this is what we've picked up in the process evaluation. These are some of the ways in which you might fix it before implementation's finished, right? So it is that kind of critical friends. But ultimately, the publishing of findings, even if they're negative findings, is something that's agreed from the early stages to manage those expectations. So I think in practice, collaboration and partnership is important, and I think it gives you all these different things I've said, but managing expectations early on is key, so then you're not faced with, severing perhaps a relationship or those difficult conversations.
Thanks.
Thanks, Lisa. So we've got the two next questions are related to something that I was a little bit interested in getting your insights on, is how you can apply digital tools or AI. So Resmel, did you want to get us started on your question first, and we can follow up with the second question afterwards?
Sure, thanks, Cecilia. Excellent presentation. So my question is around artificial intelligence, and I'm not sure if you mentioned it in your talk, but do you use any sort of artificial intelligence tools for some of your rapid approach work? And then if so, how has it impacted the work?
Yeah, I think that's a key one, right? And it's something that we're all grappling with at the moment. So I'm the old school person in the team. So there is a subgroup within our team that is particularly when we work with large qualitative data sets. There's been some work done by the team, I would say probably started around the time of the COVID-19 pandemic, where we were thankfully getting access to really large qualitative data sets, but because of time pressures, we couldn't analyze data manually. So the team started to look for different kind of machine learning approaches. A lot of it has some level of AI, where the model is kind of taught to look through qual data in different ways and to come up with different, at least to highlight different patterns that we then might make the decisions about whether we explore further or not. So you've got kind of a human in the loop type of model, but yes, where you're able to look through pages and pages of either reports or interview data, or even looking at things like Twitter feeds or things like that. So I think there's definitely, and there is a field now that's starting to take shape called the big qualitative data field, where there's a lot of work that could be done. In smaller data sets, we still haven't ventured into the world of AI to make sense of small data sets. We tend to rely a lot more on manual methods at the moment. And we still haven't ventured into the use of AI for writing. So we still tend to do all of write our papers. But yeah, I think it's definitely where things are going. One of the areas that we're exploring at the moment is, especially because of our link with the patient safety research collaboration, which Sarah mentioned at the beginning, where we know as a system, for instance, that there are hundreds and hundreds of patient safety incident reports that cannot be looked at, of course, manually. And many times, because we get scared when we have lots of qual data and we don't know what to do with it, it's really rich information about why some of these patients' incidents continue to take place in the healthcare system that we're just not tapping into the richness. So a lot of the work at the moment is how can we develop techniques, drawing from kind of more traditional machine learning, but bringing in some of the kind of newer approaches in AI to make sense, to flag important changes that need to happen in practice, whether that's translated into kind of a dashboard system of alerts. So yeah, that's definitely an area that we want to explore.
Great, thank you.
Really interesting. And Celine, did you want to follow up with your question?
Yes, I'd like to. Thank you for the presentation. And my question is, since AI tools make traditional research much faster now, how would you argue, or what are the benefits of the rapid research in comparison?
Yeah, I mean, I think that's a good point. I think some of the work that we've tried to do with the analysis of big qual data facilitated by machine learning I can send a link. There's a paper that's just come out from the team that is actually comparing two different types of analysis. And we find that even though, as you said, kind of AI-informed analysis speeds up the process, in our experience at least, we always needed a human in the loop to help train a model around interpretation. So there were elements of finding kind of trends that, yes, could be picked up, but the way in which we might link those different patterns or the way in which we might contextualize them still required that human interpretation. So I think there are aspects perhaps of analysis that can be facilitated with AI, at least where the technology is now, but there's still elements of making connections, I think, that where you still need a research team. Now, if you combine both, then potentially you could develop quite a rapid output, as you expressed, Celine. I think a lot of the early kind of summaries and categorization work that tools like the Real Sheet allow you to do, I don't know how easy it would be to create that with an AI tool. I think potentially you could look at an AI tool at a separate stage later on to create a quick synthesis of findings potentially. But I don't know the real-time summaries of findings with the categorization that we've described before that also allows you to package your data according to your different sites or your population and to then make those connections. It could be my ignorance in terms of how you use them, but I think there's definitely room for them. I don't think that they're there to completely replace the more kind of rapid techniques that we've discussed.
Do you think in the coming years that that's going to be more and more the route that we go down, maybe apps developed to kind of help categorize this data, input the data, and then have synthesis as the output? Do you think that that's kind of the direction it's going in?
I think so, yeah. And we already see one of the things we discussed with the team this week, for instance, was should we start attending some of the training that's already being offered on, AI and qualitative data analysis to see what's out there. We do lots of rapid evidence reviews as well, and more we see AI being used to facilitate, screening, synthesis, etc. I think it's definitely the direction it's going. There's still, like I said, elements where I think that you need, even if you're reducing potentially the size of the team, you still need that kind of human in the loop to make those connections that the models probably won't be able to. Yeah, I don't know. I mean, I'm trying to think about ways in which the team could potentially. I'm just thinking of ways in which you might be able to train models into using some of these approaches, and then have team members, be completely replaced by AI. A lot of the work that we do during analysis as well, and it's one of the things I mentioned in one of the slides, is many times we think that the tool, so something like a real sheet, which allows you to summarize and categorize data in real time, people get very bogged down in terms of what the tool looks like. But for me, the tool is more about the conversations that it facilitates. So a lot of the interpretation that happens is actually happening through team discussion.
Yeah.
And my only concern with thinking of AI as a tool that just does analysis is that we forget that qualitative data analysis is not just about, summarizing and categorizing data. It's actually about interpreting what's coming out. And a lot of that interpretation comes through discussion. And it's about that narration of the individual researcher to other members of the team first, in terms of what they're finding, what's coming out, members of the team processing that, members of the team making connections with what's coming out of their sites, and then as a team reflecting and finding trends and identifying that. And that is how meaning is made, right? It's made as a team, and it's made through those discussions. My concern will be that the AI facilitated analysis will rely a lot more on summary and categorization, which is one layer of analysis, but won't allow us to won't facilitate really that interpretive level, which is where that human brain has looked at all those different scenarios and has brought in the literature that has shaped that study from the beginning. I don't know, maybe I'm old-fashioned, but I'm just finding it that, we tend to think of analysis in one way, but actually it has so many other layers.
No, I kind of agree on that front. I attended a webinar yesterday that was discussing kind of barriers to implementing things in clinical practice, and one of the discussion points was really about the fact that we are always facing our evaluations. We get the very visible barriers, like the workflow barriers, the time, the funding, all of these things, but the digging deeper, like understanding the invisible barriers, like the norms, the behaviors that are contributing to this, like the values of the people that are implementing these new innovations. So I have a question. We'll go back to the chat in a second, but I just had a little bit question in terms of how, just if you want to comment on how rapid evaluations can also safeguard against to ensure that that data is not missed, or those invisible reasons for things not working out are kind of captured. If you had a comment on this or your experiences in this. I think you touched earlier about the discussions and the group discussions you have, but if you had another comment on that front.
I think definitely a team reflection is key. Sometimes, we're not a team that relies too much on conceptual frameworks and uses them, quite rigidly. But I think many times frameworks like CFIR, any other, sometimes it's conceptual frameworks that are linked to a particular type of behavior change model or intervention. Many times bringing those in, particularly at the stage of design, allowing, using them to shape the data collection instruments, and then bringing them in our case, we integrate them into our real sheet, but then we look at them during other stages of analysis. It's that constant sense checking of different conceptual domains that I think add a layer of kind of rigor, but also allow us then, as you were saying, Sarah, to really question, what are some of the things that we haven't looked at, or the questions we didn't ask, or the people we didn't talk to. What are the barriers that might have been hidden by an implementation team that we didn't pick up? So it becomes that interesting sense checking exercise. And that's worked, quite well for us in practice.
And that's great. And that's where those iterative cycles kind of would work. Great. Rupesh, that you have a question in the chat if you'd like to take the floor.
Sure. So my question is around when we have limited time and as the rapid analysis requires some expertise or some level of training for someone to do the interviews at the same time, do the note taking and note down the key points. So if someone is well versed with the question which is under study and has domain knowledge and has background of that framework which is being used, for example, CFIR, which is quite complex for a beginner. So those issues like how to handle them where, like you don't have enough time, and if the data is quite, like wide or diverse, and if the study is exploratory, where such challenges are there in the qualitative analysis using the rapid review. So how to handle these challenges?
Yeah, I think it's a really good question. And one of the things that we deal with quite frequently is we get approached, for instance, by clinicians who maybe don't have a formal evaluation background, but yet they want to learn how to do evaluations and then to incorporate them into their daily practice. So many of them join the team, they do placements with us, or they might, even do more formal research programs. One of the things I say to them all the time is less is more. Keep it simple. Keep the questions guiding the evaluation focused. Focus on the key kind of concepts of that intervention that you want to look at. Sometimes it feels like they want to boil the ocean. So look at all the components of a program, all the components of an intervention. So for us, especially if you're just starting out in the field, the advice is always simplify. And if you are developing an evaluation design with focused questions, that means that also from a data collection and analysis point of view, your interviews will be shorter. You'll have a data set that's easier to handle. The other advice that we give is table-based methods are your best friend as you're starting out. So embarking in something more complex like thematic analysis it's pages and pages of text and then line by line coding and everything, and many times you don't need thematic analysis to analyze qualitative data. That's something that we mention quite frequently. So table-based methods, framework analysis, we find is something that's very easy for people just, quite recently embarking on just working with qual data. It's easier to grasp. It's easier to visualize trends because you have basically a spreadsheet of your entire data set across all your cases and your different topics. So I would say if your interviews are focused, they're shorter, your data set is smaller, and if you use a table-based approach, many times it's easier to see those trends, to categorize your data. I agree with you. I think some frameworks are overly complicated. Sometimes when we use CFIR, we use general domains and we say, some of the analysis has been informed by or guided by, but you might not be looking at absolutely everything because it becomes incredibly tedious. And then you're also in a way using it as a checklist, and it's not meant to function in that way. But you don't necessarily have to use that. There are other kind of simpler approaches. I think going back, for instance, to the original perhaps program theory or logic model that's shaping that program or intervention that you're interested in looking at, and then breaking up your data sets in relation to that, and just making that comparison between, okay, well, this is the program as planned. This is what we've decided to kind of do. This is what the evaluation showed in practice. This is what was done locally. Sometimes just doing an analysis that's as simple as that can make the process a bit easier.
Thanks, Rupesh. And I think there's a little bit of a follow-up question from Erica, but I'll read this kind of out. So initially it was, have you ever involved patients and clinicians in your rapid analysis, and what sort of support might they require, which you touched on a little bit earlier. But perhaps one new part is, has it affected your timeline? So personally, Erica has not used patients to support her rapid analysis, but have involved clinicians, and they have contributed with quite some important insights during analysis. So perhaps commenting on how the engagement of actual implementers or patients, your experience with that, and if it's affected timelines and project
it's a really good question.
processes?
It's a really good question. So we use the acronym PPIE, so Patient and Public Involvement and Engagement, and it's key in any type of research or evaluation. I had so I have a person in the team who is our PPIE lead, and she's kind of the person driving a lot of this work. One of her early studies was about doing PPIE within a rapid research and evaluation context. And she, the question that she asked her is, can we do this in a meaningful way with time pressures? So there's a paper out there that that she led on that might give some useful ideas around how we do this. And from that, we've developed something called SPRINT, which are strategies for PPIE in rapid research and evaluation, which I'm sure we can circulate, or it's on our website as well. But the idea here is the way in which we work, and it's similar to this concept that we were talking before about having kind of set pools of people that you can incorporate, kind of bring into different stages, is we have a panel that works with the team across all of our different projects, whether it's a 2-month rapid evidence review to an 18-month rapid evaluation. There's always lived experience researchers who either have, in many cases, been through some of the hospitals where we work, so they know the context, or they've experienced a particular condition that we're studying, or they've been through surgery. So there's one element of lived experience that is relevant to that evaluation. And they are there as a member of the team. So they will join team meetings, they will discuss projects, they will review documents, they will input on analysis, they will provide feedback on strategies for dissemination. So there's already an infrastructure created within the team to facilitate that. And I think in that case, it doesn't produce delays because you're not having to go and search for people who might be interested and screen and teach them about research and what we do. Now, one of the issues we faced recently is that because they do all this work with the team, they've become what we might label as professional PPIE members, right? So some of them, now know more about research than anyone else. And we're embarking on quite a large study at the moment looking at particularly at inequalities in surgical outcomes in patients who come from very deprived areas. And our PPIE members definitely do not tick that box, tend to be retired or sometimes middle class. They now have a lot of knowledge about health services research. And so a lot of the work for that particular project has centered now on creating a database of other people interested in taking part in research who might be coming from different backgrounds. But the work of searching, screening, making sure that they're happy, that they know what they're working on, is something that happens in parallel to everything else, so that the moment that their input is needed, especially in rapid timeframes, that the infrastructure is already there. So I would say it's definitely important to maintain the strategies for involvement and engagement. You probably, as a rapid response team, need to build that infrastructure so that the moment that you need to tap into any type of advice, that's already there for you. And the same thing comes with working with policymakers, for instance, which is also a very difficult population to engage with. So that, again, we've created over the years a link with UCL has a public policy unit, but also there's a few kind of parliamentary units that have a particular remit to interact with academics. And so building those connections and having that infrastructure. So again, you're tapping into a bigger pool of researchers if you need that, tapping into your PPIE group, whether it's your standard group or a bigger database. You've got a link with policymakers.
Great, thank you. And there was just a little point in the notes in terms of the usefulness of maybe engaging 2 interviewers at the same time. I think it was follow up to an earlier comment to kind of help facilitate things being picked up. So it's often hard for one interviewer to pick up to record, make notes, and also to feedback other questions that might be useful to dig a little bit deeper. So thank you,
doing interviews in pairs potentially, and yeah.
And we have time for just one quick question, which is the last question from Anna Bergstrom. So I think I'll read this one out. So have you evaluated the level of capacity you have developed among clinical staff through your trainings, and if they use it in a useful way?
That's a good question. I mean, to be honest, I think that's definitely an area where we probably need to do more work. Within the training system that we have, we do where that's attended by quite a few clinicians, and we've created some kind of bespoke training for hospitals as well. We have an evaluation kind of process where we might ask them about the impact that the training had in terms of their confidence, in terms of their ability to incorporate some of these rapid evaluation methods in practice. We do a follow-up a few months after the training to see if they've been able to embed anything in practice, which is all in the form of an online survey, which isn't, of course, always answered. So at the moment, it tends to be captured in that way. The other thing we have, I suppose, are the more long-term partnerships of working with clinicians in practice. So our team is normally brought in to provide that methodological expertise and to potentially deliver on the ground in terms of doing the actual data collection, analysis, interpretation, etc. But the clinical teams are the ones who might be proposing the initial ideas, who might be facilitating that access to patients and other members of staff, who will be there to kind of guide the team in terms of the more clinical aspects that no idea. And I think overall it's developing those partnerships over time and then seeing them embark in evaluations as well, where they might be leading a lot more of the methodological work and we might be there as advisors. So I think that's it's a nice thing to see in terms of impact. But yeah, and then we have the clinical academic roles in our division, which are becoming more and more common, which is actually clinicians who then embark in formal degrees. So they will do a master's, either a master's in research or an MPhil, and then will continue into a PhD. And most, so for instance, I supervise about 10 PhDs in parallel. And I would say I probably at the moment have a 50-50 split. So 50% who will come from more traditional social science background, and another 50%, which is interesting, who are clinicians who are, as part of their PhD, they're learning about qualitative research. Several of them are actually doing process evaluations. And then, of course, they'll get their degree, but they'll take the skill set, and they'll be able to apply it in their clinical roles. And many of them will then remain with a clinical academic role where they have a percentage of their time that's allowed for research and evaluation versus the kind of time for clinical practice.
Cecilia, and thank you, Anna, for that question. So that kind of brings us to the end of the session. But just before that, I just want to really thank you, Cecilia, for your wonderful presentation. I've been writing some little take homes, but you really gave us a really nice introduction to and kind of summary of rapid evaluation methods, and it was great to see how you created the RAP sheet or the real sheet to be able to facilitate that kind of rapid sharing and comparison of data, and also to kind of ensure that the data collected is quite consistent across the board or across different sites. And it was really nice to see what's happening with Stream, which will become, you mentioned it's a nice go-to for people that are just getting started. It's a nice starting point for all of us to understand what really goes into putting together these processes and doing them in a way that kind of really maintains the standard and the rigor and the robustness of the data that you're collecting. So really thank you so much for your time. Thank you to all the participants for coming today. And if you do want to leave some feedback for us, would really welcome that. You can just scan the QR code that's showing on the screen now. And before we kind of all leave, I just want to do a little quick notice. We were all, a lot of us, maybe some here, were able to, were lucky enough to go to the Zurich Impact in-person conference that occurred just last month. We now have a save the date. So we do conferences every 2 years, and the next conference will be taking place in June of 2028. So we really wish to see a lot of you there. So pop it in your calendars so we can, so we can all meet in person. We just really want to thank everyone again for this webinar. And also, if you would like to share this webinar or watch it again, it will be up on the YouTube channel in the coming days. So thank you, everyone. I hope everyone has a nice evening and a nice rest of day. So thank you so much. Thank you, Cecilia. Thank you.